Hey, so what brings you in today?
So I've been having these weird raised spots all over my arms, and then also I have been having a lot of numbness within both of my hands and then starting to go into my feet. And then I've been losing a lot of hair in my eyebrows and eyelashes.
And when did these symptoms start?
So I'd say that hair loss started probably a couple weeks ago gradually, but I just didn't think anything of it because I figured it was just from washing my face. But these just suddenly appeared about 2 days ago.
Let me take a look. And are they painful at all?
No, they're not painful, just kind of inconvenient.
And have you been experiencing any muscle weakness?
Yeah, a little bit, especially over the last week.
Have you been in contact with any wild animals in the last 5 to 8 years? It seems that you might be experiencing some symptoms of Hansen's disease, commonly known as leprosy. It is caused by the bacteria Mycobacterium leprae. Some other symptoms of leprosy include these discolored patches of skin, and they may be flat or raised, painless ulcers on the soles of feet, loss of eyebrows and eyelashes, muscle weakness, paralysis, enlarged nerves, and eye problems.
So if I came in contact with the armadillo like 5 years ago, why is it now starting to act up?
Well, M. leprae has an incubation time of 9 months to 20 years and a very slow replication time of 12 days to 14 days. M. leprae produces no known toxins, but it does have certain virulence factors that help it to enter host cells and evade immune response. There are 5 different subtypes of M. leprae, and it just depends on how strong your personal immune response is to it. The nurse is going to come in for further testing.
Hi, so the doctor sent me in to take a couple of samples. So today we're going to be doing a skin sample, and then I'll also be taking some blood, if that's okay with you.
Okay.
Just going to gently remove it. And with that, this will be sent off to the lab for some PCR testing, and then also to look at what's going on under the microscope. And then with your blood sample, that will be also analyzed by our lab.
Diagnostic labs include skin smears from the earlobes, elbows, and knees, skin biopsies from the edges of affected patches of skin, PCR testing, and blood testing that results with the following: elevated leukocyte count, decreased hemoglobin count, low hematocrit, increased liver function test, and presence of elevated serum C reactive protein. Dapsone works by inhibiting folate synthesis in the bacteria, and it's well absorbed by the gut and metabolized in the liver. Rifampicin works by inhibiting bacterial DNA-dependent RNA polymerase and facilitates direct blockage of RNA elongation. Clofazimine works by interacting with bacterial membrane phospholipids to generate antimicrobial lysophospholipids.
So how does Mycobacterium leprae infect our patient's host cells? So M. leprae is an intracellular pathogen, which means it likes to live in host cells. So for example, M. leprae can be found living in macrophages, and it's able to do this by entering the macrophage using its mannose-capped glycolipid found on the surface of the bacteria to interact with the mannose receptor of the macrophage. Mycobacterium leprae is also able to infect Schwann cells of a region found on the nerve cell, and it's able to enter these Schwann cells through its phenolic glycolipid 1 that interacts with laminin 2, which is a protein found on the outer region of Schwann cells. Let's take a look at what's happening under the microscope. So Mycobacterium leprae must be characterized using acid-fast staining because of the mycolic acids found within its membrane. So you can see in this image the presence of a bunch of pinkish purple bacteria, and especially those bundles of bacteria are called globi. So taking a look at some histology here, we can see in this bottom image the presence of foam macrophages, or foam cells. So what's going on is that M. leprae has been able to enter into these macrophages and now has caused the buildup of lots of lipids within it, which causes that appearance. So now we're going to move over to these two images, and these are histological stains of the skin samples that were taken from our patient. So in the first image that appeared, you can see the presence of sheets of histiocytes, and that's usually a big indicator that this M. leprae infection is going to be characterized as lepromatous leprosy. And then when we take a look in the bottom image that appeared, we can see that it's supposed to be the same sample, and you can also see like the pinkish purple bacteria found within the cells. So while Mycobacterium leprae is not the fastest replicating bacteria, as it takes 12 to 14 days just to replicate after successfully infecting a host cell, it's able to build up in numbers after a couple of years if the immune system of the patient is able to not sense it. So in this case, and what you see is that we have our patient here. And our patient's immune system is not really responding to M. leprae because it was unable to activate T helper cell type 1, which would have been really helpful in destroying M. leprae. However, the patient's immune system does try to do something about this infection by activating T helper cell type 2, which then releases interleukin 4 to then stimulate B cells that will then differentiate the plasma cells to produce antibodies. And these antibodies are meant to be targeting Mycobacterium leprae. However, Mycobacterium leprae is an intracellular pathogen, as mentioned before, so these antibodies are unable to reach the bacteria within the macrophage. So this results in our patient's condition, which is lepromatous leprosy, which explains why the patient has presented with raised nodules on her skin in different regions of the body. Because the bacteria is not destroyed or killed, it is able to continue replicating and spreading via these macrophages and are then able to reach other parts of the body. For example, Schwann cells of the nerves, which can also lead into how the nerves are affected and why there is this peripheral neuropathy that occurs with leprosy.
So your lab results came back, and it looks like you have the lepromatous form of leprosy, which is the more aggressive form. So we are going to treat this with multi-drug therapy. We're going to use 100 milligrams of dapsone daily, 50 milligrams of rifampicin daily, and 600 milligrams of clofazimine daily. We are going to ask that you come in every few weeks just so we can make sure you are not having an inflammatory response. We will need to treat with corticosteroids.
Every year, there are 200,000 new cases of leprosy diagnosed around the world.
Regions most affected by this disease are located in Southeastern Asia, Africa, Central America, South America, Pacific Islands, and southeastern portion of the U.S.
In 2020, there was 159 new cases of leprosy diagnosed. Specifically, 81% of those cases occurred in Florida.
This has led healthcare officials to believe that leprosy has become endemic to the southern portion of the U.S.